We're here at the CROI in Boston, and we're here talking about research in women. And we want to cover some of the important pieces that were at the conference here, and of course your own work as well. Monica Gandhi from University of Pennsylvania.
UCSF.
UCSF. I got you in reverse, but
yes.
we'll go with that.
Sorry.
You're UCSF, and we have Sarah Wood, who is from University of Pennsylvania.
Correct.
And we appreciate you taking the time to come to this piece of educational information about women. And I hope that you will be able to give a piece of what, you did a presentation at the conference.
Yes.
So maybe we should start there.
That particular presentation was on pre-exposure prophylaxis, and specifically was on the issues that can lead to renal problems, kidney problems with the tenofovir and FTC combination. The particular study I presented, though, was only in men. And in fact, what was brought up as a glaring deficiency of all the presentations when we talked about them is that we don't have data on tenofovir FTC exposure in women, like the exact amount of drug that they get into their system, and subsequent toxicities. And so when we make comments on bone and kidney with tenofovir FTC, we cannot extend those comments to women. And I think that's a problem that was highlighted by this presentation. The one good thing I want to say about this CROI, though, is that there were 3 women leaders of the conference this year. And because of that, did you notice in the abstract book that they put a whole section on what are the relevant abstracts to women? And they have an entire index, Tuesday, Wednesday, Thursday, all the things to look at for women. So to me, it felt really different this year because of that.
Yeah, absolutely. I think that there was a very strong interest in women, and for me, I'm an adolescent medicine physician, so I think there was a lot of emphasis about what's happening with young women in particular. There's a number of abstracts at the conference that highlighted just the extraordinarily high incidence rates we're seeing of HIV for young women, particularly in sub-Saharan Africa. In the Depivirine vaginal ring talk this morning, they talked about a rate of 8.2 per 100 person years in their trial, which is just remarkably high and higher than most of the rates we've seen in other trials. So I think there is a big emphasis on really trying to find the agenda to meet the prevention needs for women. And I also think that this morning, the panel or the platform presentation on transgender women did a fantastic job of also highlighting that when we think about women, we also need to be developing a really relevant research agenda for transgender women as well.
Yeah.
Do you feel there's a correlation between the research and the real world in the uptake and the use of the ring or other prevention methods? Because I know in another panel they were talking about that relative concern.
The thing I'd say about the real world that's presented here is they had a lot of data. We were talking from the Women's Interagency HIV study, the WISE study, which is as kind of real world as it gets, because it's a cohort study of 9 sites now or around the nation that have enrolled women and are looking at factors. And this year, there was actually a lot of data from the WISE. It was somewhat sad. There was a lot of data on how women are not doing as well as men in many ways in the United States.
In study or
in this kind of real world
yeah.
way, in reality, and I think that's what's so great about the WISE, but they weren't doing as, they had more cognitive decline. They had high rates of high blood pressure and diabetes.
On treatment?
Interesting. So the cognitive decline was on treatment. They were on treatment, and yet there was more cognitive decline, and the authors were suggesting that it was related to stress and to chronic stress. The high blood pressure and diabetes is really high, which we knew, but they're not controlled very well. Even though people are taking medications, they're not reaching benchmarks of where they should be with high blood pressure and diabetes.
They were taking the medication for the high blood pressure?
Yes, but not controlled very well. And then a lot on kind of isolation and stigma and depression and stuff we've seen before, but the real world was represented, I think, in realistically, that women don't do as well as men in this country.
And I think the stigma piece is important too, because we obviously know that communities of people living with HIV are still in an era where there's a lot of stigma and discrimination. I think as the epidemic and a lot of the focus on the epidemics shifts to MSM, that women are getting isolated in a way, which is not to say that they are more stigmatized, but I think it's a different type of stigma and isolation that we're seeing in women now, at least here in the United States.
So what would be the classic or traditional stigmas that a woman might face that men might not perceive as stigmatizing?
So I think that some of the stigma can be interrelationship stigma. So we know that women are at higher risk for intimate partner violence, and so there may be stigma about a diagnosis within the confines of the relationship or the home. But in terms of seeking health care, there may be stigma that women with HIV are facing in that aspect as well. In my data that I presented today, we found that when we looked at long-term rates of having a suppressed viral load in adolescents, that overall adolescents had very high rates of treatment failure. But what I was surprised to see is in our treatment cohort, and we treat mostly young MSM, but the women who were in the cohort did significantly worse. So they were far more likely to have viral failure and to have it early. So I don't know what the exact answer is, but I think that there is something that's going on, particularly with young women in care, that is really acting as a barrier to staying retained and staying
But it's worth
pointing.
pointing. I think it's worth pointing out that the U.S. data was a lot around, and has always been around, how women don't do as well.
Yes.
And then there was a lot, and there was an emphasis here
On men. Yes.
on women and men in, basically everywhere else, but in resource limited settings, where women have, it's always been the flip, that women get on antiretrovirals earlier, they enter through
I was going to say,
fatal
early
care.
on we had a lot of good news with women.
And so I think you could say that there is generally good news overall. The U.S. is, and sort of Europe, and there are different settings where women aren't doing as well. And we even had a symposium on how men need to enter the equation, because women are doing much better, and they're testing and they're taking their ARVs worldwide, resource limited settings, and men are the ones who are falling behind. So it depends on the setting.
Absolutely.
So the setting meaning geographic?
Yes.
That's what I was hoping you'd say that, because it seems as though there's a big difference between suburban and urban, and we in fact had some panels on women in an urban setting, talking about some of those challenges that you just described.
Yeah. And then I think you mentioned the Tepivirine ring trials, and maybe you've already spoken of them, but I think that was big news, that for the first time there's a ring that could possibly release an antiretroviral slowly over time and protect women. But it wasn't, I think the percentages of protection weren't as high as I'd hoped.
Yeah.
And I think that is going to come out more after the exuberance wears off.
Yeah.
Those percentages protection wasn't as high as we hoped.
How is the ring utilized? How is it in the process, in the procedure, or the process of having sexual activity?
So basically the ring is inserted on a long-term basis. So you put the ring in, it lasts for a month, and you change the ring at the end of a month. And one thing so it doesn't need to be around the time of having sex.
So you don't have to remove it for sex?
You don't remove it for sex. In fact, you're not supposed to remove it at all until it gets to that end of the month period. What's interesting about the ring data that came out today, and the thing that really sort of broke my heart a little bit, was that in women under 21 there was no benefit at all. So they showed that although there were 2 ring trials that the data came out today, and in both trials there was preventative benefit in preventing acquisition of HIV, but in neither trial did have any effect in under 21. So the younger women didn't really use it, and they found that the reason that it didn't work was that people didn't use the product. But I think this speaks really well to what you were saying before about how does this correlate with the real world. And I would say I do contraception for teenage women all the time, and we have a vaginal ring that's used for birth control, and we have very low uptake rates. In fact, young women are really not interested in a product where they have to stick something inside their vagina.
Gotcha.
And so it may be that it's a good option, but it may not be an option if the cultural norm in your age group isn't to use an intravaginal product.
If a person uses it, presumably it's successful. Is it successful for anal sex?
So That's the big question,
Yeah.
and it doesn't seem like that's necessarily going to be the case. So Sharon Hillier on the first day gave a really lovely trial about where we're at with all the sort of prevention technologies. And when you use the vaginal ring, the tissue concentrations in the vagina are very good, but to be able to get tissue levels in the rectum, you would basically have to have the levels of the drug high enough to go all the way through the blood and then get distributed into the rectum, and it doesn't look like that's necessarily going to be the case with the ring. So if women are having both vaginal sex and anal sex, then it may not be the best preventative option.
Yeah, that was a big worry. And then if we talk about with the vagina and the rectum for a moment, then I think it would be good to talk about the fact that I think women have different tissue levels of drugs, even when they take it orally. And we already knew this for tenofovir. And it may possibly explain why women didn't do as well in the PrEP trials than men. You know, it's like they had to have perfect adherence to get those right vaginal tissue concentrations. But then I think this is an important research presented today that the TAF pill, you know, which is sort of being touted as, okay, it's safer than tenofovir, it's better for bone and renal, it's going to be the new tenofovir. This group at UNC that always looks at tissue levels really great at that, Angela Kashuba's group, looked at tissue levels of the active form of tenofovir with a single dose of TAF, and there was hardly any tissue levels of the active form of tenofovir with TAF. 83% of tissue, you know, of the people didn't have any tissue levels of the important. So that speaks to what TAF is going to be like if they think about it for PrEP. I mean, worried about the general protection.
So are you looking forward to any of the injectables down the line, the long-term injectables, depot injections and so forth? How does it strike you?
Yeah, I mean, absolutely. I think cabotegravir, both for treatment or PrEP, is very exciting. I think there's going to be, again, getting from the research setting to the real world, one of our biggest challenges with cabotegravir is that it has a long tail. So once you
get off of it, you'd have to get on to something else.
You'd have to bridge with PrEP afterwards, or bridge with Truvada for oral PrEP. And so if we're really marketing this to be an answer for people who aren't going to do a great job of being adherent to oral PrEP, but then we may ultimately need to bridge them with oral PrEP when they come off, I think there's just going to be, it's going to be a difficult water to navigate.
We'll definitely have to tell them that, okay, this is the whole picture, and then explain to them that if you decide to not come in for the next year, we have to get you on another treatment to wean off of it, titrate off. Yeah.
I mean, two particular aspects of long-acting relevant to women are that we had some data presented today about injection site reactions and kind of safety, but that was all in men. And then the other, though, on the flip side, is that people in the women's world are tremendously excited about the possibility about long-acting contraception put together with long-acting antiretroviral. So you're like doing prevention in two ways, if those could be connected. Same thing with the dapivirine ring, that there's lots of commentary about co-formulating the hormonal contraception.
So women have more of a problem with site reactions or less?
Well, no, we don't have any data. That was...
Oh, it was all men.
The Eclair was, all men. And I think that I don't want to, this is one thing, and we had talked about this before in a previous session, that we keep on saying, oh, we don't do enough clinical research in women, we don't enroll the women in trials in adequate enough numbers. And I keep on thinking that was going to get better. And actually, the person will remain nameless, but when he was presenting an important switch study, he said, and as this is really unfortunate, there were not very many women, as we've been seeing. And I thought, unfortunate, you're part of it. You were responsible for the trial. It's not unfortunate, it's a deliberate not working hard enough to get women in.
Well, it seems like you can slow down the uptake of men in the trial and just say, oh, we're not enrolling anymore. It's not a complicated process.
It's not. The ACTG has done that. They did that with 5257. It's not unfortunate. It's not a side effect. So I was, I don't want that to happen with long-acting.
You need to sign some activists and advocates to kind of, attach themselves to the trial and say, this is how you need to reconstruct it. This is how you need to operate it. And I mean, I work with ATAC, and they're all the time having to go through this over and over again with the same people. It's kind of like adherence,
You're totally right.
Adherence is another thing, you need to keep on hitting it on the head, because if people don't remember. So every time you go in for an injection, for this, they should tell you everything just like you didn't hear it before, because you probably forgot it after a month.
Yeah.
So,
you
yeah, if
keep
you're
on
not-
repeating. You
yeah.
need to get enough women in clinical trials to do
Yeah.
some sex stratifying.
Or get the stakeholders involved early
Yeah.
on in the
Yeah.
process. It does make a difference.
So yeah, and for PrEP, I think the ring might be for some that want a long term, but as far, and for the injectable, but for some it might be just something like the pill, because they just want to, they have limited times that they have sexual activity. So why bother with the anything until they feel it?
Yeah.
But it's nice to have that on board if you don't know when you're going to serendipitously have your sexual activity.
Well, I tell my patients all the time who come in and say, oh, Dr. Wood, I'm not on birth control. I don't want to go on birth control. I got burned by my last boyfriend. I don't want to have sex anytime soon. I said, most people don't wake up at 6 in the morning and say, I'm going to end up having sex at like 8 o'clock tonight. You know, a lot of the time it just happens.
Serendipitous,
So,
yeah.
Better to be prepared. Speaking of the long-actings in women, a couple of interesting posters were looking at actually implantable forms of long-acting antiretrovirals. And so these are all still sort of theoretical models for devices, but in women we use a form of birth control called Nexplanon, which is just an implantable rod that goes into the arm that slowly releases progesterone hormone and is highly effective at preventing pregnancy. And there's a couple of people who have developed very similar antiretroviral rods that could be placed under the skin and could be longer acting. And the nice thing that would give a benefit for, which is a little different than the cabotegravir, is with the long-acting injectables, if you have an adverse reaction, we can't get it out of your system,
Yeah.
so that's a longer thing. And that's not always a problem if you have good safety data, if you know that your risk of serious complications isn't high. But the nice thing about these, the potential for an implant, is if there's any problem at all, you take it out, you just go into the office and have it taken out. So, look forward to that in CROIs of the future, but that was exciting to me to see that as a possibility.
I think I spoke to John Potter today with VIV, and their philosophy is that, of course, if they found it was very safe, then they could offer it, as a prescription immediately. But if it isn't, then they have to think in terms, there's a chance that there's a risk of toxicity, and they have to put the person on the oral for a period of time. But I think they'd like to, provide it, prescribe it right away, so it's not that there's this two-step process.
Yeah,
Of
exactly.
going a month
Right, which you would do in
on-
research, but hopefully we don't have to do.
Yeah, we'll
Yeah.
have to answer the question.
Luckily, we'll have to answer that question. I mean, luckily, at least its oral cousin, dolutegravir, it's been
Yeah.
pretty safe so far. But
Exactly. So any other aspects that you want to cover for women in research? I mean, we talk all day, but we don't have that time. But we do have the opportunity here if there's something that you feel is important to cover, or challenges. I know the issue around around women in research is incredibly ridiculous.
Yeah.
That they don't seem to get how to get there.
Yes.
It's not complicated, and it's really important because then you have all in one trial.
Yeah.
If you have to then do another trial, it just doesn't make any sense at all to waste that opportunity.
The one piece of data I wanted to bring up was stroke risk, because I think you could divide the entire CROI this year into not as much treatment trials as we often have, but so not as much as that, but lots of prevention, lots of exciting stuff in PrEP, and then also complications, lots and lots of complications, and they were bone and cognitive and cardiovascular and a lot of stroke, more stroke than I had seen at previous meetings. And the one abstract I want to point out, which is an oral presentation, which was on increased stroke risk in women. In the ALERT cohort, and that's a cohort where they take ACTG cohort participants and roll them over to a cohort. And being African American and independently being female was associated with a higher risk of stroke. So that, we focus a lot on cardiovascular disease in men, but it's very good to see data that's looking at even cerebral vascular disease in women. So that's important.
Yeah, I didn't notice that with of course, the CROI was started out when there was opportunistic infections. Now it's all complications or comorbidities or whatever you want to call it. There's many things you can cover,
Yeah.
but But yeah, it's truly we've evolved to where we don't have the opportunistic infections anymore, but we do have the comorbidities.
Yeah, exactly. And that's why a lot, I think, also was mentioned on bone, because this is a very dynamic
And that
thing.
was talked about at the 7th CROI.
Yeah.
That was brought up by William Paradoley. He says, and then the very last thing he said, and then there's osteopenia and osteoporosis. And it was everybody like, it's like you dropped a bomb, you could hear it quiet.
You mean you could talk about a chronic ailment that's, that's very
And
interesting.
there then, of course, it proceeded to have problems. Not profound, but it's out there.
Well, but if it's going to happen in anyone, it's women.
Exactly.
Because they're
Well, that's
already
what
at
he was
risk.
saying,
So,
And I think in addition to the risks with HIV and thinking about therapies as well, we have to think about the added risks of long-acting hormonal contraceptions like Depo-Provera, which can also cause some osteopenia. And overall, the data has looked like there's not cumulative and added risk, but then I think this is a special category with women, and one of the things we need to think about differently is often through part of the longitudinal trajectory of their existence, they're going to be on other classes of medications that men aren't, and so I think there's always room to explore more about the ways that hormonal contraception can interact both with the disease process as well as with antiretroviral therapy.
And the treatment seems to now be given and expected to last a very long time. There's no reason to shift, although if there are better drugs with, that have achieved a better benchmark, certainly the switch can be done. But a lot of people can live a very long time with one single treatment, 10 years. I did 11 years with Fusion.
Yeah, well, those were hard 11 years. So
Bless you.
That's a hard 11 years. And that's what the only thing is I am worrying about the injectables and injection site reactions.
Yeah, well, I went through a lot of that.
It's very painful, right?
It hurts. Yeah. But where's the injections given in the
it
waist?
was the gluteal, the butt, and
the
it was
butt, okay.
it
Well,
was
the Fusion was around the waist.
Okay, yeah, right. And there's
And the women seem to do better because most women have more fat there.
Subcutaneous.
and there's
They have a different
there
style
was
of fat,
obstetrics in that here as well.
Yeah. Well, I'm really glad that you all came here and did this today because it's been very helpful, and I think being a man, you had a man on the panel, right? But he didn't have to be involved except to ask a few questions.
Yeah, we appreciate letting us
thank you
speak
very
to the
much.
audience.
Thanks for having us.
Thank you so
Thank you.
much.